Ma
لا ده أنا تاني مش موجودة في الغرب بيقول لنا لا يوتنا ده ميار لك مطابق ده كمان بكتب السنة بدنا عشان nice.
Hi, Yair. Nice to meet you across the web.
Hi, very nice to meet you too.
Yeah, thank you for presenting, by the way. We'll give everyone a chance to log in, but we'll probably shoot start about like 1:05, like in a couple of minutes.
Okay, great. Should I share the screen?
Yeah, you can.
Okay.
Yair, maybe you should also mute everyone because there's a lot of background noise. So maybe put
Yes.
everyone else on mute.
I'm not sure I can do that.
I'm gonna try to do that right now. Give me 1 second.
הוא שבר קצת את היד. שבר קטן, בלי תזוזה. אנחנו נושאים אותו בסד גבס קצר. זה בערך 3 שבועות עם הסד גבס, ואחרי זה אפשר להוריד את זה.
נחשון, שים את עצמך על מיוט, נשמה, כולם שומעים את הטיפול שלך.
אני על מיוט אבל.
כנראה שלא.
Okay, now it's working.
Yeah, and thank you for that. Yeah, I was gonna look otherwise, but thanks, that worked.
Thank you very much for inviting us.
No, thank you for presenting this, and thank you. It's 7 p.m. over there, right? So thank you for taking time at nighttime to present to us.
It's fine. And can you see my screen?
Yes,
Is it all right?
I can. Yep.
Okay.
Yeah, so we'll give everyone a couple more minutes, and then we can start.
Excellent.
All right, I think we can get going. Once again, thank you for all your group for actually participating and presenting. So all the way from Sweden, we have today Yair Katzir presenting to us. Pleasure to have you guys, and a pleasure for having you guys in the group. So you can take it away whenever you're ready.
Okay, so thank you very much for inviting us today. It's a great pleasure to be here. My name is Yair. I'm going to talk about a project we started something like 2 years ago of ultrasound-guided brachial plexus blocks for forearm reductions in children in the ED. Just a minute. Okay. So I'm a pediatric emergency physician from Israel. 2 years ago, I joined the Karolinska Children's Hospital, or ALB ED team, headed by Pia Malmquist. And currently I work both at ALB Sweden and Schneider Hospital ED in Israel, headed by Ron Berant. Today I will speak wearing my Swedish hat, though I think that probably in a month we will join you the meeting wearing my Israeli hat. And so Astrid Lindgren Children's Hospital is a tertiary hospital, teaching center, and it's a university children's hospital of site of Karolinska University. We are located over 2 sites. I'm working in the larger ED, which see approximately or more than 50,000 patients a year. it's the largest pediatric ED in Sweden. The POCUS education program started at 2017, and recently we started running our fourth pediatric POCUS course. So let me introduce the Albert POCUS team. My great, good colleagues and friends, Albano, Aaron, and Katarina. I have no disclosures, and let's start with the first case. So at 2019, during a busy evening shift, an 8-year-old boy entered the ED with a distal radius fracture. At that point, because of staff consideration and so on, we could do only sedation with nitrous oxide with supplementation of hematoma block. And we thought that it's not enough regarding the pain in the reduction in that case. So the other options that we had were, one, to put a slab and send the child home and invite him the next day for a reduction in sedation and proper sedation, or to send him to the OR. And then we thought about a third option, and that was to do a brachial plexus block and do the reduction under that block. So here's a taste, or just a show of part of the block. We can see here the needle going just beneath the axillary artery and spreading local anesthetic around the radial nerve. And we'll talk about that later. The reduction went smoothly, and we could get to a really good alignment with cooperation of the child, and everything was going fine. And the child went shortly after that home, happy. At our ED, we perform approximately 700 forearm reductions per year. Most of them are done under sedation with nitrous oxide with supplementation of hematoma block, but some are done with performed under sedation of ketamine or dexmedetomidine. And since then, we've done approximately 50 brachial plexus blocks. And now we have that alternative. So why to do it? First, it's a great replacement or alternative to sedation. There is no need for sedatives, and it's opioid sparing. It's really highly effective. It gives us a lot of flexibility with the staff and the ED resources. We saw that we can learn it quite fast. So it's a steep learning curve. And we think that it shortens the overall hospital stay. It's probably do that because there is no recovery time as we have with sedation, and less patients are sent to the OR. What we do the blocks for, so it's mainly for reduction of forearm fractures, but we do it also for reduction of elbow dislocations, or other painful procedures like suturing large laceration or drainage of large abscesses, and sometimes just for the pain management for example, in a severe deformation before sending the child to the X-ray. And I'm bringing that today to the forum because even though it's really a great alternative, I couldn't find any evidence in the literature or in social media and so on that this is done elsewhere in other pediatric EDs. And I think it's a great opportunity that you invited us to talk today, and we can discuss it here in that forum. So difficulties when performing that in children. So it's not always easy. It requires the child's cooperation. And as we know, many children tend to be anxious and to fidget, and the parents tend to be anxious as well. We had several cases of parents even getting vasovagal syncope while we were doing the block, and it surely doesn't make things easier. There are also technical problems, like in adults, it's usually these blocks, and this kind of blocks are done with large volumes of local anesthetic, between 20 to 30 cc of lidocaine. And in children, we are restricted with the allowable volume of the local anesthetic according to the weight. So many times we have only 10 cc's or something like that. Also anatomically, there is not a lot of space to maneuver as in adults, and the visualization of the nerves is not as easy compared to the adults population. So how do we do that? So first, we have to select the patients carefully, and then we have to take into consideration the ability of the child to be in the right position, the anatomy and the visualization that we get of the nerves. If we go over the anatomy, so the brachial plexus starts at the anterior rami of C5 to T1, and we can block it in many levels. So we can block it at the interscalene level, supraclavicular, infraclavicular, and axillary. We find mostly the supraclavicular and the axillary most suitable in children. We do some interscalene, but the interscalene block the innervation only to the shoulder area. So it's good for pain management of proximal humerus or for shoulder dislocations, but it's not that good for forearm reduction. Also, the infraclavicular is, sorry if there are some that are not mute. So if the infraclavicular, there are different approaches, but we find it not very practical in children because there's not a lot of space to maneuver, and the visualization is not very easy here. So I will talk mostly on the supraclavicular and the axillary. So let's start with the axillary. The axillary is a very good block to start with. The advantage is that first, it's not painful for the child. And the second, that you can do no real harm performing that, because the worst case scenario is that you will puncture the axillary artery, but then some pressure and the bleeding stops. The disadvantage is that the child should be with his arm in 90 degrees, as I will show later, and it's not always easy for a child with a deformation in the forearm or elbow dislocation. As always, we have to prepare all the equipment before. It's hard to if we forget something, it's hard to stop the block and go and fetch the equipment once you start. We need a direct line of vision between the eye, needle, probe, and the monitor. And to locate the stuff in advance in the right position. If it's young patient, then one member is doing a nitrous oxide sedation for the anxiety. One is performing the block, and another one helping with we do it in two-man technique. So the one performing the block is holding the needle, and there is an extension, and another member helps with aspirating and injecting the local anesthetic. So that's how it looks like. The child is lying supine in 90 degrees of the arm, and we slide the probe up and down the arm to visualize the nerves. As you can see here, we see the musculocutaneous. Do you see my pointer? I hope so. So
yes, we see
it.
Yeah.
Okay, great. Thanks. So we see the musculocutaneous nerve, and we see the three branches, the radial nerve coming from below, and here it is. And we can see the ulna just here near the axillary vein, and the median nerve here, lying here. And it's important to do that sliding up and down, because in a still image, it's hard to understand the anatomy. But once we understood that with sliding, so we can see that's the musculocutaneous nerve lying here between the biceps and the coracobrachialis muscle. And we see the radial nerve, ulnar nerve, and median nerve sitting beside the axillary artery and the axillary vein. Then once we located the nerves, we inject a small amount of lidocaine just to the skin, and then we can go with a larger bore ultrasound needle without pain. We use, as I said, the in-plane approach using a two-man technique. One is holding the probe and the needle, and another one helping with the syringe injecting. And we go from the anterior part, that's the needle. We're going to the fascial plane of the musculocutaneous nerve, spreading the local anesthetic. And then hydrodissecting the tissue, which means that we inject small amounts. It can be either saline, if we are using small amounts of local anesthetic, or the local anesthetic, just to hydrodissect the tissue, and then we can go beneath the axillary artery in a safe way and inject the local anesthetic around the radial nerve, as you can see here. And then we withdraw the needle and go the same way with hydrodissection above the axillary artery and injecting around the ulnar branch and around the median branch. Now in the axillary level, actually it's doing like 4 separate blocks, because the brachial plexus already diverged there, or separated. But it's with one stab, and once you see, if you see the anatomy well, and you see the local anesthetic spreading around all 4 branches, then you know that it's going to work fully. So another case, 11-year-old girl, she'd been in the ED the night before, with a distal radius fracture that you can see here. That's actually after the first attempt. And they tried to reduce it with nitrous oxide and hematoma block and couldn't complete it because of the pain. So she returned in the morning and we did the reduction under Brachial Plexus block. She had no pain at all, and we can reduce it to a very good alignment. Now moving to the supraclavicular nerve block. So the great advantage here is that the child is sitting with his upper arm in a natural position. So if he got a severe deformation or elbow dislocation, he could lay like that more comfortably. The disadvantage is that it's much closer to the big vessels and to the pleura. So again, we prepare all the equipment. We need a direct line of vision to look at the stuff, and that's how it looks like when it's in the right position, the probe in the right position. So we can see the subclavian artery and the brachial plexus just lateral to that, above the first rib, and below that we can see how close the pleura is in children. If you will look at the same images in adults, the pleura is much more beneath, so it's easier to do it, but in children everything is very close. So the technique, we put the probe just above the clavicle and start sliding it up and down the neck towards the ear. And we can see here that's the scalene muscles, and we can see the plexus between the scalene muscles, and then it converge. We can see it converge near the subclavian artery here to one plexus. And once we located the right place, we can tilt the probe caudally and then move from oblique view of the subclavian artery to a full cross section, round cross section of the subclavian artery, and then the brachial plexus appears very clearly. Once we are in place, we inject a small amount of lidocaine to the skin without moving the probe, and then we can go with the needle. Here you can see the needle. It's especially in that block. It's to any block, but in that block, because it's so close to crucial things, it's very important to see the needle tip all the time. And we go into the fascial plane. In that block, we don't go into the plexus itself, because then we will just get a mixed and not full effect. So we go into the fascial plane. We start beneath. We spread the local anesthetic. We can see the plexus just lifting above it, the local anesthetic. And then we withdraw the needle a little bit and start still in the fascial plane, and starts injecting and spreading the tissue and go above the plexus until we see it with local anesthetic all around. And a case, 11 years old boy, he was climbing a climbing wall and fell and got his elbow dislocated posteriorly. We can see here, just a minute, here, the olecranon, and that's before the reduction, and that's a distal humerus, and it's clearly dislocated. And we did the block and could reduce it without any pain. And here we see the image after the reduction with the distal humerus and the olecranon in good alignment. Just 2 more cases. And that's the youngest patients we had. This one is an almost 6-year-old boy. He came with a mid-shaft radius and ulnar fracture, a nasty one, as you can see. And he was very calm, and we could perform the brachial plexus block under nitrous oxide sedation for anxiety. He cooperated amazingly, and it was a smooth block and reduction, and we couldn't get the fracture into really good alignment. But unfortunately, there was a residual bowing or plastic deformity of the ulna, and that child could go to had to go to the OR to have a internal fixation, but at least he didn't have to go through sedation twice, and he was very the parents and the child were very happy afterwards from the experience in the ED. And that's the youngest one. That's a block that Albano performed in a 5-year-old girl with diabetic mellitus type 1. She had a distal radius and ulnar fracture, and really didn't want to go to a proper sedation, and the parents didn't want that, and so it was done with the brachial plexus. And again, she cooperated amazingly, and Albano could perform the block and the reduction very good, and to reduce it to an acceptable alignment. So just a few things that we have learned from our experience in these blocks. We have to choose carefully and select the right patient for the block, the patient that we think that will cooperate, and choose the block according to their ability to be in the right position. Usually we look at 1 or 2 sites and choose the right place to do according to the anatomy and the visualization. We use nitrous oxide very liberally, because even children that looks very calm, if they start moving and be anxious when the block starts, then we cannot complete the block, and so it's better to prepare in advance. Some technical things, so to use small volume of buffered lidocaine just for the skin, and then they usually don't feel any pain after that. And it's better to use a 2-man technique. We have more control, and if the child start to move and fidget, it's easier when you don't have to hold a long needle and a syringe. You have more control on the situation. Very important to hydrodissect. Always see the tip of the needle in the especially in the supraclavicular, go to the fascial plane. Since if you go into the plexus, then you get a mixed effect. And don't be frustrated if it doesn't work. We've seen that even when you have gained good experience, once in a while it just doesn't work well enough. And let me end, I'll finish with a short story. A couple of weeks ago, again, as always, a busy evening shift. There was no available orthopedic surgeon at that time, and a lack of nursing staff. A boy with a hard form reduction. We did the block, and the child was just sitting there, looking at his hand while we were manipulating it in all directions, and he was just smiling and looking at that. And a colleague of mine entered the room, and he looked at the child sitting there smiling, and at the pants, and he was so old, he just looked at the pants and told them, "Oh, you don't understand what you are seeing now. It's not like that usually." And we all know what it means to do hard reductions, and that's just a great alternative for that. So thank you again very much for inviting us today to talk. And I would be very happy if there would be some discussion, because I don't know if any of you had experience with brachial plexus blocks, and if it's done in other places, and I would be happy for questions and to hear your experience.
Thank you so much for presenting, by the way. Here I work at Connecticut Children's here in Connecticut. Yeah, I personally don't have an experience with Brachial Plexus blocks, so I'm interested to see if other people are doing it. So thank you. I'll be watching your video closely, so I can let the landmarks better. Question I had for you is, here for the most part, in the United States at least, we use IV ketamine liberally for all these reductions. Do you see that like this provides better sedation for those, or I'm not sure if you guys use IV ketamine as liberally as we do here in the United States over there in Sweden?
So in Sweden, we don't use it liberally. From time to time, we use it. In Israel, the other place I'm working in, we use it much more, or I think quite the same as in the US, very liberally. But the brachial plexus in the selected patient, it's really a great alternative. You don't need to give these sedatives, which we know that have effect. And usually the children are cooperate really nice and just sitting there without any pain. And then you're glad that you didn't have to give ketamine. You don't see the adverse effect of ketamine. The children can go very quickly back home after that. So I think it's really good alternative and a tool for us, the ED doctors, to use.
Thanks. Rosemary has a question, so you can go ahead, Rosemary.
Hi. This is amazing. That was so amazing. I think we're all sitting here so quiet, but like it's really amazing what you're doing. So, but I had two questions. One was you said ultrasound needle. What did you mean by that? What are you using? And then the second question was, you're anesthetizing everything, right? So motor and sensory. What about like motor recovery before you go? Like now they have a hand drop or whatever. Like, at what point do you feel okay sending them home? That was that. And then third, my brother lives in Stockholm. So hello, I know all about your institution and it's fabuloso. So those are my comments.
So we use usually they recover. It's mostly the sensory part, not much the motor part. So they can move the hand, but they don't feel. They have some weird sensation things, so they don't feel the pain, and they still can move the fingers, and we can check part of the neurovascular thing before sending them home, but they don't get back to full sensation usually. It depends on the time that they're waiting for the discharge. But because the lidocaine, well, in something like 1 hour. So sometimes we do see full recovery. And then, but most of the time we don't wait for that.
So you're only using lidocaine?
For reductions, because it's short acting, it's long enough to do the reduction even once. It's as a demonstrate the advantages. I was giving the I was doing the block, and then there was an alarm, and I went to or red code, and I went there and went back after almost an hour, and I was so frustrated that I did the block and that child will have to go to sedation or something, but he had no pain at all. Yeah, still, and we could do the reduction. So it's again giving you a lot of flexibility. But yes, because of the short acting procedure, we are using lidocaine. For other blocks, or if it's only for the pain effect, like in when I was saying that we are doing the interscalene for proximal humerus, or in other blocks like the femoral blocks, we are using other local anesthetic things like shirocaine and other.
And the needle.
And the needle, yes, sorry. So the needle, you can do it with any long enough needle, like a spinal needle, but there are specific needles for ultrasound procedures. It's mostly the anesthesiologists who are using that, but I'm sure you can ask them and get the film that they're working with. We are using some different manufacturers like Temena, and the advantage of these needles are that first they are not as flexible as the spinal ones. They are not with the cutting, they are with the blunt end. So it's more painful when you go through the skin, and that's why we are injecting some local anesthetic before that, just to the skin. But then there's less risk to harm or go into the nerve, and you see them better in the ultrasound, especially the needle, the tip of the needle, and that's very important.
Yeah, you have a question from Stephanie Conchi. He asks in the chat, what size and gauge needle do you use?
So it's usually we use the 5 centimeters or 50 millimeters long. Sometimes for deeper blocks we can use. There are also it depends on the manufacturer, but there are also 80 millimeters and 90 millimeters, but usually in children, the 50 millimeters is enough. The gauge is 23 or 22, something like that. But for the skin, we are using a small caliber, 27 G or something like that.
Yair, I have a question.
Yes, hi.
First of all, it's really, really good seeing you. I have a question. Did you experience any adverse events during or after the procedure from your experience?
Adverse effect? Sorry, I didn't get it. On? On? Do you hear me? Okay, so if it was adverse effect, or so we've done something, as I said, around 50 blocks by now, or maybe a little bit more in both sites in Sweden and in Israel. And no real adverse effect. Once or twice we had with a suprascalene, with the interscalene block, we got Horner syndrome, which was a transient Horner syndrome, and that's something that is described in that block. And usually it's only transient. And in the other blocks, no real adverse effect or long-term effects.
And I'll just read what questions that they're putting onto things. So Adam Sidis asks if for like, and you know, to very anxious kids, what do you use to prep them? And then what's the lower age limit that you go down to? I saw that but you say you use nitrous really on everyone?
Yeah, especially in the young children. So okay. Adolescents, usually we don't need that. We can talk with them, and if we see that they're not really anxious, we are not using anything. And in the younger patient, so the youngest one was the one I said Talban was doing. She was 5 years old, and I've done blocks to 5.5 and 6 years old, and they all cooperated very nicely with nice nitrous oxide. I must say that in Astrid Lindgren, the nurses who are doing the nitrous oxide sedation, they are really, really good, and they are talking with the children and get all the anxiety dissolved.
And then Will Mack also had a follow-up question to that. Do you guys use intranasal Versed over there? Because here in the United States, there's another drug that we use to like prep kids before like a minor procedure. Do you guys use that over there?
What?
Intranasal Versed or midazolam?
Oh, we don't use it much in Stockholm. In Israel, we use it sometimes. I've never tried the brachial plexus blocks with that. I use it quite a lot to other things, but not to the brachial plexus block. So I cannot answer if it's useful in that situation, but I suppose it does the same as the nitrous oxide regarding the anxiety.
Okay. And then Erica Constantine had a question. How long does it usually take, from start to finish, including the prep, the nitrous oxide, and getting everything ready in a cooperative patient? So, how long this whole procedure takes?
Once you gain experience, so at the beginning, it takes quite a lot of time just to look for the right place and deciding and preparing everything. In Stockholm, now that we gain some experience, it can take something like 10 minutes, 15 minutes from start to end. Just the child is entering the room, we are preparing everything quite fast and go directly to the right location, injecting, and it takes something like 10 to 15 minutes.
Adam Sivitz wanted to know when you're publishing this case series and about an international study group, so we can learn how to do this.
We are working on that. So we start preparing a case series, actually 2, and hopefully we will publish that soon.
Follow-up question to that, like how, what kind of training did you get, or how do you train somebody else? Do you train them on a real person? Here's a kid, or you don't have trainees, or, so it's great to hear, but then how do we bring it to our shop,
Yes, so I think it depends on the previous knowledge of doing procedures under ultrasound. So somebody who is experienced with blocks, and the best one I think to start with are the forearm blocks, the ulnar, the distal ulnar and median nerves are very, very easy to perform. You don't need any previous experience. You can there is no risk to harm the child, and they are not very painful. So it's good to start there just to gain the experience to have control over the needle and the probe. And once you gain experience with that, you can move on to the more difficult blocks, maybe the femoral block, which is not that complicated, but it's a little bit deeper than the forearm blocks. And then you can go to the brachial plexus. I would suggest starting with the axillary, because again, you cannot do a lot of harm there. So it's good to start there. We have trained several fellows and attendings, physicians. They all had some experience with doing blocks and other procedures, so it went very quickly.
Yair, do you mind if I fill in? My name is Albano. Sure. I'm working with Yair in Astrid Lindgren in Stockholm. What I wanted to share is that we started with ultrasound for not such a long time ago, and as Yair says, it's not possible to train this in a real manner to get somebody to get experience with the dummy, because there are so many factors that need you to have access to. So you need a real patient, but you cannot start with doing an axillary block. That means that you need to have a good handling of the needle. So starting with my first block with actually the tibialis posterior and the ulnar block in the forearm, those are quite easy, they are quite superficial, and you don't need a lot of stuff around. And as Yair says, you cannot do too much harm. And going from that to the axillary, when you have done a couple, it's not that complicated if you have somebody helping you out. That was my case with Yair. And after that, when you have done about 5, 6, it goes fast. Then you get the confidence, and then you're ready to do them in a short. I mean, you do them quite quick, and it's an amazing difference compared to the hematoma block. I mean, you put this 10 minutes extra of your time, but the results are not comparable. You have a patient that it's not having pain at all. Most of the times when I do this and ask the kids what was the worst with the procedure, they always say that they feel some puncture in the axilla, and that was the worst. So it's like doing a local anesthetic that they feel most, and then afterwards you can manipulate the arm as much as you want without any pain. So I think it's something that should be used in many other places, because it doesn't need so much education or so much time to get there, and you are saving all these complications of the ketamine or all the kinds of sedatives, plus you're saving time and probably money as well. So we really recommend to start getting into this way.
Yair and Juan, you can answer this question. So Stephanie Cohen wanted to know what does the orthopedic surgeons in your shops think about this? Here, there's the concern for compartment syndrome. So sometimes blocks are not recommended. What have your orthopedic surgeons said about your blocks?
If it's a low risk for compartment, we don't do that for example, for pain in elbow fracture, in Gartland fracture, in supracondylar fractures. We don't use that because of the risk of missing the compartment syndrome. But in forearm reductions or fractures and elbow dislocations and low risk for compartment syndrome, you can use it really liberally. The orthopedic surgeons are not worried about that, and the effect of the lidocaine is short, so it's 1 hour and you're off. So and that's one of the reasons that we are using lidocaine, not other derivatives of it or bupi, because they are long lasting, and we don't want to miss a compartment if it progress.
Well, thank you once again. I learned a lot from this, so definitely we'll be watching this. And then just remember, for those who are interested, I'll send a recording link, so that way I'll be rewatching this, and then I'll definitely probably be sending you some questions once I'm brave enough to try it out. Thank you again so much for presenting for us and participating too.
So thank you very much for inviting us. It was a pleasure, and I will be happy to answer any questions after that through the mail or any other way. And that's it. And good places to start looking at is I'm usually looking at the different places, but I'm looking a lot at Highland ultrasound. It's a really good place to learn and look at blocks, different blocks, and also some of the anesthetic sites like Nisora and Astra and so on. They have really good stuff on that.
Thank you. And I'm looking forward for your case series. So that way I'm eager to read it through once you guys published it.
Thanks.
All right. Thank you so much, everyone.
Thank you very much.
And spring will come to Stockholm soon. Don't worry.
Yeah, it's still snowing though.
I know. I know. Hang in there. Ciao.
Yeah. Thank you very much. Bye, guys.
Bye.
Thank you, Yair.
Thank you.
Great talk, Yair. Nice to see you.
Hey.